Assalamu alaikum wa rahmatullahi wa barakatuhu. Hi guys, this is Shahadat and today I'm going to read a scientific paper for you. This paper was published in openaccessjournals.com and it was published under the diabetes management section. And this is actually a case report on diabetes management. The title of this paper or this case report is A Clinician's Guide to Inpatient Low Carbohydrate Diets for Remission of Type 2 Diabetes toward a standard of care protocol. This paper was authored by Mark Cucuzella, Adele Haidt, Caitlin Peterson, Laura Saslow, and Rory Heath. This is the third video in this series, and I'm going to start reading from patient selection part today. So if you want to listen to the previous parts, please refer back to the watch the other videos that I've already uploaded in my channel for part 1 and part 2. So without further ado, let's start. Patient selection. Let's make the screen a little bit bigger as well. Patient selection. The clinical approach described in this document focuses on adults with diabetes, HbA1c from 5.7 to 6.5%, and T2DM or HbA1c over 6.5%. These populations were selected due to strength of evidence base for utilization of low carbohydrate diet as therapy, the health burden of the disease, and the potential clinical challenges to implementation as outpatients. These patients must be able and prepare to, number 1, use a blood glucometer to check serum glucose if on insulin or insulin secretagogues, sulfonylurea, and meglitinides kind of medication or group of medications those are. Number 2, communicate with the healthcare team during the LCK diet intervention. These guidelines will not extend to patients prescribing with an acute unstable medical condition, pregnant women or those breastfeeding, pediatric patients. Next section, pre-diet evaluation and counseling. The evaluation and counseling of a patient prior to initiation of a LCK diet can occur in either an inpatient or outpatient setting. Initial intake should include evaluation of patient's current symptoms, past medical history, comorbidities, current medications, and baseline laboratory workup. Patient components of the past medical history include date of diabetes diagnosis, time of progression to insulin requirements if relevant, diabetes medication history, history of hypoglycemic episodes, and diabetes complications or comorbidities. Additionally, history should include polyuria and dehydration. Special attention should be given to the symptoms and timing of diagnosis and insulin requirement to elucidate any component of latent autoimmune diabetes in adults, or in short LADA, or maturity onset diabetes of the young, MODY. A basic laboratory workup should be completed to rule out acute pathology and establish baseline matrix. Initial laboratory tests should include the following. Number 1, complete metabolic panel including liver function tests. Number 2, complete blood count. Number 3, thyroid function tests. Number 4, HbA1c. Number 5, standard lipid panel. Number 6, urinalysis. Number 7, physical measurement of weight, BMI, waist circumference, and blood pressure. Number 8, additional tests may include, this is another point basically. Additional tests may include vitamin D, C-peptide, uric acid, high sensitivity C-reactive protein or HSCRP, advanced lipid panel, fasting insulin and homeostatic model of insulin resistance, HOMA-IR, glucose tolerance test, GTT, etc. Clinicians should note that GTT can be inaccurate if the patient is already on LCK diet. A patient's readiness to change and support are essential for proper initiation of this therapy. The attending physician should share knowledge and information on using LCK dietary intervention for T2DM as an option to usual care. An exploration of the patient's motivation, psychological and financial situation can give insight into the patient's behaviors and barriers, example disability, employment and relationships, to the success of this dietary and behavior change intervention. In particular, capacity to buy foods and prepare meals appropriate to the intervention should also be determined. Initial counseling may be done by any trained and qualified member of the healthcare team. If a patient chooses this intervention, the patient's care team, including pharmacy, nursing, and dietary or nutrition, should be alerted in order to align patient care in a way that will help patient be successful with this intervention. Next section, patient education. Adherence, satiety, and simplicity are critical to early success. Appendix 2, Getting Started on a Low Carbohydrate Diet, provides a brochure that can be used to educate patients in how to begin a LCK diet. Additionally, free resources for clinicians to use for patients' education can be found at many online sites such as dietdoctor.com. The entire healthcare team should be familiar with the general principle of how to reduce dietary carbohydrates as a therapy for T2DM, so that information given the patient is clear and consistent. I think it should read, so that information given to the patient is clear and consistent. The appropriate level of carbohydrate reduction to meet therapeutic goals will differ among patients. However, an amount of less than 50 grams of carbohydrate per day will put most adults into nutritional ketosis. During this state, the body relies primarily on fatty acids, and a small amount of ketones can be detected in blood, urine, or breath. Importantly, this differs from ketoacidosis, in which an absolute lack of insulin causes uncontrolled lipolysis and large amount of ketones cause metabolic acidosis. Ketones may be measured, but we do not advise this for the majority of our patients due to costs and added complexity. However, if patients understand the use of urine strips or a breath or serum meter and wish to use them, we do not discourage this. Measurement of urine ketones can be helpful in the initiation phase of this therapy. A less restrictive low carbohydrate intervention also has therapeutic potential, even if it does not lead to a state of ketosis. LCK diet emphasizes whole food sources of protein and fat, low starch vegetables, full fat dairy, nuts and seeds. Although this intervention can be done as a vegetarian diet, the diet allows animal products and seafood to be consumed to satiety. In counseling, the emphasis should be on foods and general carbohydrate restriction rather than monitoring macronutrient content. Adequate protein and fat intake at each meal to give a sense of satiety and satisfaction should be emphasized. Most authorities agree on about 0.8 to 1.0 grams of protein per kilogram of lean body weight, but this can vary based on the individual's need and energy expenditure. Examples of low carbohydrate sources of protein and fat are meat, fish, poultry, and non-meat sources such as eggs, full-fat dairy, and low-carbohydrate nuts such as pecan and macadamias. LCK diet encourages LCK diet encourages the liberal inclusion of non-starchy vegetables, particularly leafy greens, and sources of natural plant fats such as avocados and olives. Fiber from a variety of plant sources is thought to be beneficial for the gut microbiome, but this emerging area of interest is beyond the scope of this paper. Reference 3536. LCK diet allows intake of natural fats to satiety. These include any non-trans fats such as olive oil, coconut oil, avocado oil, full-fat dairy, and butter, along with the fats naturally associated with whole food protein sources. As it has not been determined that saturated fats in foods contribute to adverse health outcomes, foods thought to be sources of saturated fats are not restricted for this intervention. Reference 37. Carbohydrate restriction strongly limits the intake of grains, example rice, wheat, corn, oats, etc., and grain-based products, example cereals, bread, biscuits, oatmeal, pastas, crackers, etc., starchy vegetables, potatoes, corn, legumes, sweetened dairy products, fruit yogurts, flavored milk products, etc., sweetened desserts, gelatines, puddings, cakes, etc., and most fruits. In general, fruit cannot be accompanied. Fruit cannot be accommodated within the daily carbohydrate intake. However, unsweetened berries may be included in limited amounts. We recommend non-starchy vegetables instead as sources of fiber and micronutrients. I think I'm going to stop here and make another video starting in the initiating dietary intervention subsection. So yeah, I'll see you in the next video. Take care. Bye bye.